this person has a right to choose and they have a right to decide what's best for them. Speechies spoke a lot about this sense of transformation in themselves as a clinician. I needed to adapt. I needed to find new ways. My old ways of working or what I'd perhaps learned at university didn't serve the community setting. Yes, a student or a graduate needs to be able to, know how to do an assessment. They need to know when to refer for instrumental. Absolutely. They need to know compensation rehab techniques, but also they need to be able to think about a person in the context of their lives.
So where does this research come in?
Dysphagia Research Bites.
Welcome to the Dysphagia Research Bites podcast, which is a podcast designed to make dysphagia research more clinically digestible for speechies, especially those working in home and community-based settings. My name's Chantelle, I'm a speech pathologist, and I started this podcast because dysphagia care doesn't just happen in hospitals. It happens around kitchen tables, in aged care facilities, and in everyday life. Community dysphagia work is complex, it's nuanced, and it's often underrepresented in conversations about swallowing. So, if you're looking for clinical tips and thoughtful, evidence-informed conversations that actually translate to practice, you're in the right place. I'm joined today by Dr Simone Howells. She is a senior lecturer in speech pathology at Griffith University in Australia. After working in hospital and community health settings in Australia and the UK, Simone has been in academia for the last 13 years and completed her PhD in 2020 in the area of community-based dysphagia care, which you'll hear more about today. Simone is particularly passionate about improving the healthcare people with dysphagia receive across all settings, but particularly in the community setting, as well as enhancing student preparedness to work in this area through practical and relevant learning experiences. Tell us, Simone, why you chose, this particular area of research, and just give us an overview of the research of your article.
Yeah, absolutely. So the paper that we're talking about today is called Dysphagia Care for Adults in the Community Setting Commands a Different Approach, Perspectives of Speech Language Therapists. That was published in the International Journal of Communication Disorders back in 2019 now. It was part of my PhD work. But in the conversations that we've had, Chantelle, you've been quite reassuring that this is still very much a contemporary piece in this space. I know that there's been no further publications in this space. So it's still one of, the key papers that we have about community speech pathology practices for dysphagia. But the overview is basically that we interviewed 15 speech pathologists about the dysphagia service that they worked within and their practices with adults in the community setting, so people living in their own homes. But it was actually a follow-on study to an earlier paper that we have in this space as well, which was a survey. So we initially had surveyed 144 speechies about their clinical practices. And then as part of what's called an explanatory sequential mixed methods design, the intention was use the survey data for our kind of initial summary of the data, and then interview the speechies for a deeper, more nuanced understanding of the topic. So that is exactly what this one that we're talking about served to do. It was to get this really lovely, rich, in-depth conversation about what it's like to actually practice in the community, working with people with dysphagia. Yeah.
Yep. And so what were the key themes that came out of this research, Simone?
It was a qualitative design, as I mentioned, like conversations, interviews. And so we used what's called content analysis to look at the data. So when we were looking at the content analysis, we took the meaning units, or the things that people said that were really content rich, and then grouped them into things that were similar. And so, for example, one of our early categories was that dysphagia practice is influenced by somebody's condition or their presentation. So that speechies were saying, I consider what the health condition is as part of my management. So we came up with, I think it was about 8 different categories. And then they start to collapse into what we call sub-themes and themes. So imagine it almost like a tree where the theme is sort of sitting at the top, and that would summarize the whole data set. So that is community commands a different approach.
Yep.
But then below that is these themes and categories. So our sub-themes were, there were three. The first one was skills and mindset require adaptation in the
Mm,
community. So
mm-hmm.
as part of that speech, he spoke a lot about this sense of transformation in themselves as a clinician. I needed to adapt. I needed to find new ways. My old ways of working or what I'd perhaps learned at university didn't serve the community setting appropriately. I needed to tweak it. And then the other themes were, or sub-themes, sorry, were that the values and approaches are also different in the community.
Mm-hmm.
And obviously, that's in contrast to other settings. So, for example, the acute setting, most of
Yep.
the speeches that I spoke to had previous experience in the hospital setting.
Mm-hmm.
And then we're sort of thinking about the community in contrast to that
Mm-hmm.
and acknowledging that, yeah, there was this adaptation and also that the values and their approaches were different.
Can you go into that a little bit more in terms of, maybe some of the values that were different, or when you say approaches, do you have some examples that the speeches gave of that?
Yeah, yeah. So, sitting under that sub theme specifically were three categories, and that was holistic viewpoint.
Mm.
So, this
Mm.
idea that the speeches were able to be much more holistic in the community. When you're in someone's home, you can almost see how to think about them as this whole person. They're not in a hospital bed and in a gown. There's this world around them. There's, photos in frames and food in pantries, and you're
Yep.
able to really start to get a sense of who they are and think about them much more broadly. Um, the other category there was client autonomy. This
Yep.
sense of this person has a right to choose and they have a right to decide what's best for them.
Mm-hmm.
Um, and that we had a much bigger role in the community setting of kind of meeting them where they are and working that out together on balance of risk and other things. And the other one, which is perhaps not surprising, is carer engagement.
Mm-hmm.
And those carers were family members, but some of them were friends.
Mm-hmm.
Um, and just this idea of the carer has a really important function in the community setting, much more so, I think, than in other settings, because often they're there or they're the one sourcing products, they're the one checking in, they're the one communicating often with the health professionals coming and going from the home. And so, yeah, one of the main findings was even if the patient didn't think that they needed speech pathology or that there wasn't a role for the speechy in their dysphagia management, there was probably a role for us with the carer.
Yeah, just thinking about, the different environments, like you said, being at home, just having that context. There's so many things that we see that we wouldn't know about when they're in hospital.
No, even the most well-crafted questions wouldn't get us to that information in the hospital setting.
Absolutely. And even, if we're asking our patients certain questions as well, they're not necessarily going to know or anticipate, potential difficulties that they might have as well, because, it's not until they're in that environment that they might think, oh, okay, I definitely need help with this.
Absolutely, yes. And follow-up studies as part of my PhD, we took a similar qualitative approach and interviewed clients and carers. And that's exactly what came through, was that it wasn't
Mm,
until they got home that they realized what they needed help with. Or it wasn't until I put suggestions to them about did the speechy do this or would this have been helpful, where they thought, oh, actually, I didn't get that. And yeah, it would have been.
mm,
So sometimes they don't know what they don't know as well. And
yeah.
I think a really important role for us is options and giving them those options.
I just want to go back to the first theme because I think that was really helpful how you just went through the sub themes there.
Mm.
So back to the first theme, that was
Yeah.
skills need adaptation. Was that right?
Yeah, skills and
Were there,
mindset require adaptation. Yep.
yeah, were there a few sub themes under that one as well? Are you able to talk through those?
Yeah, yeah. So the first one was that the dysphagia practice is influenced by the client's presentation and condition.
Mm-hmm.
So I think that is probably quite self-explanatory, but yeah, just considering like what are they also managing in the context of the dysphagia? For example, if it's Parkinson's disease, but they've recently had to hand in their license, they're no longer driving. Well, that
Mm.
actually plays into what this patient's priorities are right now, or where their grief and loss is sitting at the moment. So constantly coming back to what's the underlying reason for the dysphagia,
Yep.
and then what else is that also, creating barriers or enablers for them regarding.
Yep.
Um, the second subcategory as part of that theme was speeches require a different skill set. So we've spoken
Mm.
about that, this acknowledgement of like, oh gosh, the skills and the training that I have aren't quite enough right now, or um, you know, I'm needing to draw on something different here, and maybe it's something different that I don't have, but how do I get it? Um, the last subcategory in that particular subtheme was interacting with primary care and community agencies. So exactly what
Mm.
we were just alluding to is sort of, yes, I'm one person in this puzzle, but who else can I be linking in, and how do I do that? And because I was
Yep.
speaking to speech pathologists across Australia, but at a time when NDIS was partially rolled out.
Mm.
So I know we're under a really different kind of set of practice circumstances now, but it's still an ever-changing feast. And of course, then with changes to my aged care and stuff as well, just this idea of how can we be linking in our patients and their caregivers with primary care and community agencies, and what's in my area and what would be really helpful, and how do I kind of
Mm.
reduce the barriers for this person to be able to access these things? So an understanding of, service and pathways, and
Yep.
that's obviously um, something that comes with just experience and asking a lot of questions.
What do you think about community roles for new grads? So thinking about all these other skills that we need, and you mentioned, sort of the counselling and linking in, communicating with other professionals, a lot of skills that, yeah, do sort of develop with experience. Do you have any thoughts on new grads stepping into community roles?
Yeah, like bottom line, it's got to be with support.
Yep.
And I would fly that flag for every area of practice in every setting, of course.
Hmm.
But particularly in community settings, in people's homes and their real lives, and just this, nuance to the way we practice that I think often does only come with experience.
Yep.
But I think we also have a really important role in putting on my other hat as lecturer and teacher. I think we've got a really important role in equipping students for practice
Hmm.
beyond the medical setting when it comes to dysphagia.
Yep.
Um, because I think we've done that well. I think that is something that I could say, is across all university programs. And I think generally as Australian graduates, we come out with really strong skills in dysphagia. We know that our skills
Hmm.
are in hot demand in places like the UK, but I think we can take it a step further. And I think we need to be able to bring in other things, so psychosocial aspects of care,
Hmm.
um, those practicalities. Yes, a student or a graduate needs to be able to, know how to do an assessment. They need to know when to refer for instrumental. Absolutely. They need to know compensation rehab techniques, but also they need to be able to think about a person in the context of their lives and
Yep.
where they're at that time, and obviously bringing in those aspects of the ICF that I think we also do really well in communication.
Mm,
But I
yes.
think we've still got a ways to go for dysphagia. I think we've just always thought of it as something very anatomical, very
Mm,
physiological.
yep.
And yeah, the structures involved lend themselves to that way of thinking. But also, at the end of the day, it's a person, right?
Yep. And yeah, you've answered what was going to be sort of my next question on that is, why do you think there has traditionally been such a focus on dysphagia from sort of a medical perspective, from a hospital perspective? Um, because I know that when I started a role in a private practice, we had a fairly large team of speechies, so there were about 15 of us. And there was just a common theme that was popping up in supervision with a lot of these therapists, and not necessarily, new graduates or not just junior therapists. And it was about just feeling a bit out of their depth and not really knowing how to approach dysphagia in a community setting, because they felt that, their knowledge, which was primarily sort of, had a medical kind of focus, a lot of the time it just didn't apply or didn't fit with their particular clients.
Yes, yeah, absolutely. And how much problem solving goes into those roles, I think.
Yep.
Like when I was chatting with the speechies, they were saying things like, so I go out to my boot and I realize I've got a half cup measuring cup because the patient didn't have measuring cups. So I give them mine. And it's just like, yeah, wow. Like you found it in the boot. You realize they didn't have one. You found a solution. This immense problem solving and just pivot constantly.
Yep. Got to be resourceful in the community.
Very, very. I think that's it. Yeah.
Yeah. Um, and was there another theme? Did you say there were three key themes?
Yeah, so that middle one that I talked about, or I guess like the second sub theme, was values and approaches are different in the community context. And so that was comprised by holistic viewpoint,
Yep.
client autonomy, and carer engagement.
Yep. And then was there another one as well?
Yeah, the last one there was organizational influences impacting service delivery. Yes, so the categories that comprise that one were that there was a huge diversity of structures and policies.
Mm-hmm.
Not surprising, but certainly what the data showed us was that, across Australia, across all the different services and settings, or services rather, where these species were working, it was an incredible diverse structure and policy, but then also diverse service capacity and resourcing. Yeah.
And can you tell us a bit more about the settings where these speeches worked? And you've mentioned it's obviously for patients in the community. And also when you say community,
What do I
which sort
mean?
of, yeah, exactly.
Yeah. We, as I mentioned this was PhD work for me, so there was three amazingly brainy supervisors on the job with me, and defining community was really tricky.
Mm,
What is what is the community? And of course, I'm the first to acknowledge that, for example, an aged care facility is someone's community.
yeah.
That's their home. But wasn't the scope in these particular research studies simply because of the level of support and all of the different structures that are in, something like an aged care facility. It's not
Yep.
the same as somebody managing at home on their own.
Yep.
And so same for like specialist disability accommodation wasn't the
Mm-hmm.
focus of this work for the same reasons around aged care. There's obviously incredible complexities and nuance to those settings
Mm,
that we had to kind of find a line to draw somewhere.
yep.
But research in both of those areas, both aged care and specialist disability accommodation, so needed.
Yep.
We're starting to make inroads there, but yeah, still much to do. So yes, in terms of what is community for the purposes of this research work, it was a person living in their own home,
Mm-hmm.
receiving supports whilst in their own home. So either as an outpatient in a
Mm-hmm.
community health centre or indeed in the home.
Yep. Great. And I'm not sure if you got this data or not. I can't remember. I read the article. I think it was a week ago now. But I wanted to ask if you reported on the types of diagnoses of the clients that these speech pathologists were working with.
We didn't in the interviews. So in this
Yep.
particular paper that we're talking about, no.
Mm-hmm.
But we did as part of the survey. So that
Yep.
study that came first, where we had 144 species complete that. If you're
Yep.
listening and you did that survey, thank you. Um,
That's a good number.
we
Well done getting
It
that
was an
many.
amazing number. I don't think we would get that number now. I think people have got research and survey fatigue, which is completely understandable. But yeah,
Mm-hmm.
thrilled with that number. Um, we found at the time that they were seeing a multitude of different conditions, but that
Mm-hmm.
neurological conditions were dominant. So stroke and prog neuro
Yep.
were, yeah, particularly common.
Another question for you. Why do you think there is so little research on dysphagia management in the community? Because, I mean, I don't know what it's like in other countries, but if I think about where all of the speech pathologists are working, where most of us are working in Australia, I would think that most people would be based in a community setting. If I'm also talking about nursing homes and supported disability accommodation, and yet there is so little research. Why do you think that is?
I've thought about this a lot. Look, I think like the first thing that comes to mind, it's not as sexy, right? People's
Mm,
lives, people's realities are messy.
mm-hmm.
And I think that as humans, not just as speech pathologists, but we might have a bit of a disposition there. We like things to fit in boxes, and
Mm,
the neater the better. And certainly from a research point of view, yeah, great. Like, if research is clean and contained, winner, winner. But we know that it rarely is. So I think that there's a part of it that's around that kind of appeal. But I think
Mm,
more than that too, dysphagia practice for speech pathology is actually still really fresh.
mm-hmm,
So it became part of our scope of practice in the US in the 80s. And as we know,
mm,
Australia followed suit. The Dysphagia Research Society wasn't formed until 1991.
mm.
So it's in most of our lifetimes. And we know that research takes time. And so I just think that like at the moment we're in our infancy in many ways, and we've had to spend, those first 30 years getting, the foundations established. What
Mm-hmm.
is, normal hyoid movement? And then, okay, well, what does it look like if you've had a stroke? Is there a difference depending on where in the brain that stroke occurs as to what that hyoid then does? We've had to be quite focused on what is dysphagia, what is the impairment, but with a globally aging population living longer with more chronic conditions and a consumer preference to remain at home, stay out of hospital or aged care as long as possible. There's really key drivers leading to the need for community care. There's these drivers saying, yeah, great, manage people in the community. So now the research has got to catch up.
Yes. And I find it's such a complex area of practice. So I've worked in hospitals and in the community, and I've found that, the trickiest sort of situations and presentations that I've had to deal with have been in the community. And, that might be due in part to the fact that, I don't have a medical team and a multidisciplinary team around me like I do in the hospital. But, you know, we definitely need the research from that perspective as well. And, that's not the first time I've heard that sort of, community practice is not sexy. I've heard it referred to in terms of disability. So I did a lot of developmental disability work in a previous role, and someone said the same thing, disability is not sexy. There's not as much research in this area. And yet this is my personal opinion, these are some of the most complex areas of practice. This is where we need the research.
Yeah, absolutely. I
Mm.
mean, we need like a TV series about like the sexiness of community healthcare or something, just to really level up with those ED and hospital-based dramas,
Oh,
right? I think
yeah,
that'd help. Yeah. It was Grey's
absolutely.
Anatomy that led me to think speech pathology adult practice might be cool. So yeah, maybe that's the missing piece.
Yeah, Grey's Anatomy in the community.
Yeah.
Love it. Do you think there are some, key sort of resources or clinical tools that speech pathologists in the community should be aware of and maybe have in their toolkit?
I think the most important thing is actually thinking about the questions that we're asking of patients and
Mm,
caregivers.
hmm
Something like detailed case history. Something like the swole qual does start to tap into concepts of activity and participation, but it's long, it's quite wordy. I still don't find it that accessible for families.
hmm
Um, and I don't think it has to be something, that's been published to be able to get a clinician what they need from an interaction. And I just think really detailed case history questions aimed at
hmm
understanding someone's activity and participation. I think we understand
Yep.
the impairment level pretty well.
Yes.
Um, but yeah, things like, what did life before dysphagia look like for them, and how's it looking and feeling now? Was
hmm
going out for meals or gathering at a family member's house weekly something that they did before? Because maybe it was, and they're struggling to, work out some enablers to keep doing that. Or maybe it wasn't, and our own values or our own habits around eating and drinking and socializing aren't the same. So it's more just about getting curious, and I think spending the time asking the questions to build the picture.
Did you guys come out with a new dysphagia cookbook?
As of last week, now Beyond the Blender, Dysphagia Made Easier is the second edition in what's now a two-part series of dysphagia-friendly cookbooks. They've been developed by my Griffith students over the last probably 10 years. And so they go through very rigorous testing before they can end up in the cookbook, and many don't, eventually meet the standard. But it's really important for us that this maintains or continues to be a free resource. So it's available for an electronic download. But yeah, we're really thrilled to have that out. Another 32 recipes that adds to the already 32 that were in circulation from the first edition.
Amazing. And I'll make sure I'll put those links to those in the show notes as well for everyone. As we come to the end, Simone, are there any sort of tips that you have for therapists, or, even just a key sort of takeaway from your research that you want to share with everyone?
I think if I could leave listeners with something to ponder, it's who are your local university contacts? Is there an opportunity for you to be offering placements in this space? Is there an opportunity to be collaborating on research in this space? Because we need clinical and research champions working together to progress this work. I think we're all guilty of probably having overflowing plates and too much to do already. But if we combine our powers, we can probably achieve a lot more. So certainly I'd really welcome anybody to approach me if that's an area of interest. But also I think from a clinical point of view, a clinical tip is just similar to what we we're talking about before. Don't rush, take your time in the interactions, stay curious. Think of the carer as your patient, that it's not just the person with dysphagia, but it's actually the team. That's a very important finding that came out of my subsequent PhD work, is just like, even if the patient's saying they're all good and that they're, maybe not needing a lot from you at this time, check in with the carer. What do they need?
I'd like to say a big thank you to Dr. Simone Howells for taking the time out of her very busy schedule to discuss dysphagia care in the community. I'm sure this conversation is going to resonate with a lot of speeches. Thanks for tuning in to the Dysphagia Research Bites podcast. If you want more dysphagia education, then head over to Instagram at Dysphagia Community or www.dysphagiabites.com. Bye-bye.
Bites.
I stuffed up my chopsticks.
One thing that you had to